Hello, and thank you so much for joining us today for the webinar, Some Tips and Tricks in Composite Resins. It is a great pleasure to introduce to you Dr. Carlos Fernandez-Villares, whose aim during this presentation will be to discuss a work procedure which guarantees aesthetic and good restorative results. Dr. Fernandez-Villares earned his degree in dentistry at Complutense University of Madrid and has postgraduated in aesthetic dentistry. He is a collaborator professor in the Master of Aesthetic Dentistry in Madrid, UCM, since 2004. He is also a collaborator professor in the Continuous Education Program, Anterior Composite Resins module, and Clinical Cases module in the Complutense University of Madrid since 2006. He is a member of the Spanish Society of Dental Prosthesis, an author of several articles in the area of aesthetic and restorative dentistry. He lectures internationally and in Spain in aesthetic and restorative dentistry. Dr. Fernandez-Villares has a private practice that focuses on aesthetic and restorative dentistry in Atzero and Villares Dentistas in Madrid, Spain. We'd like to thank Dr. Fernandez-Villares for being with us today and DT Study Club for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Fernandez-Villares at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Carlos Fernandez-Villares.
Hello, welcome everybody. I know you're there. I don't see you, but I know you're there. My name is Carlos Fernandez-Villares. I'm from Spain, from Madrid. And I want to share these minutes with you talking about composite resins. I named this lecture Some Tips and Tricks in Composite Resins because I think that composite resins are the things that we use more in our daily practice and is a material that we need to control to get more difficult treatments in dentistry, and of course is the most done treatment every day in our practice. When we talk about composite resins, and today I need to thank GC Company for the invitation to this webinar. It's so important, the first thing, that is we need to see. And I always like to start with a sentence that I read on the book of IDACA, that is Solutions for Dental Aesthetics, that it says that what we see with our eyes is not all there is to see, that we need repeated experience to reveal the whole. That means that when we see our restoration that we made 10 years ago, at that time we say, oh, this is totally perfect, this is beautiful. And then we see 10 years later and they say, hey, who the hell made this? And the answer is us. So the most important thing is to know what we are doing and to see what we are doing and train our eyes to see and to be more critical with our restorations. The other sentence I like to mention is one from the book of Liars, from my friends Anna Salat and Jordi Manauta from the group Study Italiano that I'm a member, that it is mandatory to understand the color of any composite resin prior to use it, even if only involves to open the different strings and compare the color. That means you need to know the material you're using prior to use it in the mouth. So let's talk about how to select a composite resin and how we choose a composite resin. If we read literature and we know exactly the materials we're using, it's very important to know that there are several types of materials and they have their own indication. We don't need to say, okay, micro-hybrids are not used for this, or nano-hybrids, or nano-fillers, or whatever. We need to know where to use every material. And there are some properties that are going to tell you that are very important in our practice to know exactly if a material is okay or not to use it in our restoration. First property is the handling of the material. For us, it's so important, the handling of the material, because we're gonna use it every day, and we need to make our life easier, our restoration every day easier. And what means handling of the material? It means that the composite don't stick to the spatula. We're going to make some tricks to avoid that the composite stick to the spatula, that sometimes converts in something horrible for us. The second thing is that we need to have enough working time. That means we need to work with the light of the equipment, not to work in the darkness. Sorry, but if we work in the darkness, we don't see what we are doing. And the third thing is that we need a material that allows us to reproduce the dental anatomy, and to reproduce it and not make that it is modified after. That means if you build up a mamelon, you need that mamelon to stay in that form that you made with your spatula, and the best thing is to make it with a material that don't stick to the spatula and with light. We can say the companies, okay, let's change the composition of the material because I want to improve the handling. There are some things that we can make for improve the handling of the materials. One is that we normally use some gases in the spatula with a spray of alcohol, and what we do is to continue maintain our spatulas dry. And with the spatula dry, we avoid that the spatula stick to the composite or the composite stick to the spatula. That is something that can make your treatment very horrible. There are other people that what they do, they say that they don't want some rest of small hairs of the gas in the spatula, and what they do is to put the spatula into a glass of alcohol, and then they dry it in the air to have a very dry material. But sometimes for me it's not so good to have a glass of alcohol there working next to the patient. The other thing that we do when we use our material is to preheat the composite resins. For this there are several literature that says that if you preheat the material, you will have more advantages than if you don't do it. For example, you can reduce viscosity, you can improve the flowability of the material and decrease the film thickness. In the other hand, the people that say, okay, don't preheat the material, is that they say that you can increase the polymerization shrinkage. But the fact is that most of these articles are made in vitro studies. So if we follow the literature and our practice, we've been using preheating materials for several years and we had very good results. And there is an article of one of the master in aesthetic and restorative dentistry, that is Pascal Magne, and written with Roberto Carlos Spreafico, that they say that when you use a micro-hybrid or a nano-hybrid restorative material, it is recommended to preheat the material to facilitate the placement and minimize the risk of interlayer gaps. So if Pascal uses, let's use it because it's a reference in restorative dentistry. So one of the properties that we want to have in our material is a good handling. The second property is the polishing, is a good polishing. That means in our practice, easy polishing, few steps, not so much a step to have a good shine, that we need a few steps, and if we can only have one step, it will be better. The other thing is that long-term maintenance of this polishing on our material. For sure, the golden standard in this material are the microfiller, but they are not strong enough, so we need to have a balance between microfiller and the new materials. About the shades, we need to obtain a shade that is similar to the natural color of the teeth, and we need at least different opacities. And what we normally do is to compare different cells. In this case, in this type of 0.5 cells of enamel made with the my shade guide, the shade guide of Style Italiano group. This is in this case, this is the inside, the color opaque inside, the A2. This is the translucent, the standard, and the junior enamel. You see the different opacities between them, that they allow you to pass more light or less light there in the diamond of Superman. We need to understand what material are we using, and we have in the G.ænial anterior composite, we have different type of name colors. That is, for example, the standard, the outside and the inside. In the standard colors, we have the A, B, C. This is more for dentin and for cervical restoration, and for sure every material now have the bleaching composite resins. Then a very easy way to reproduce the enamel, that is to use a junior enamel, adult enamel, and senior enamel. Young patients, middle-aged patients, I'm not going to say what is middle-aged, and senior patients, because everybody wants a junior enamel. And inside colors to disguise the fracture line, only in the A side, in the A side, because we want only to disguise the fracture line, and some effect colors, like the translucent, the incisal, and the cervical enamel. It's very important to know what is every letter, because we need to know what material we are using. For posterior, the system is very simplified, and we have the P, that is a posterior, A1, A2 till A4, the junior enamel. If you want some different effects and translucency, we can even use some incisal enamel, but the most important thing is the anatomy in posterior, because if we have a good anatomy, we can use maybe only one color, and we can obtain very good restorations without doing so much. So we have the material, the composite. We have some rules or tricks to choose it, and then let's make how to use it without problems. Addition works, but it needs to be in a special way, so it's very important to use the rubber dam. There are several types of rubber dams. The most important thing is try to use it the best way, and for posterior, for anterior, there are several ways to do it. The most important thing is that to use a material that works good in your hands. Try different type of rubber dams and have some techniques. Let's give you some rules that we use in our practice. This is the one that we use more, and to make your life easier. Let's give you some advices about this, about the rubber dam. First of all, don't go to the big holes. Go to the small ones, and start from the third one in the normal holes, and use this for the molars, this for the premolars, and this for canines and incisors. And very small ones, so we're gonna need an additional lubricant for the rubber dam. For example, we use oxalate gel. That is something that goes very well with water, and we don't use Vaseline now, because if you use Vaseline, the problem is that then it's very difficult, it's very hard to eliminate the Vaseline when you put the rubber dam, but you need to make the rubber dam flexible just to not break the holes. If we want to simplify our system, we can say that this is the universal clamp. We can use this in the molars for posterior restoration and even for anterior, because we can isolate everything, but in anteriors we can use some special clamps to retract the gingiva and to have everything under control, but this is one of the most universal clamps that we can use. We put it first and then we go with the rubber dam, very flexible with the lubricant, and we don't have any problem. If we use other type of clamps, what we do is to put it, goes there step by step using the flows, and put it under the gingiva and floss it with a knot to have everything under control in a dry field. We have the composite, we have the adhesion, and now we need to know what materials we are using. We need a good product, but okay, there are a lot of good products, but let's make some question and let's try to answer this question to know how to do it in addition. Let's try this part from the clinical point of view. That means I'm not a researcher, I'm a person that works in the clinic every day with patients, and I want that my restoration works for a long time for my patients. So the questions that I'm gonna put here are which type of adhesives are available in the market and what problems they have. The second thing is that what can we do clinically to improve our adhesion? The third thing is a very typical question of the patient. How many times can we guarantee an adhesive restoration? And the last one is which one should we buy or should we use? To answer the first question, now the classification is being simplified. And now we don't talk more about generations, and we talk about etch and rise adhesive or auto-etching system. In the etch and rise adhesive, we can divide it in 3 steps or 2 steps. 3 steps is the etching phase, the primer, and the bonding in a separate way. The hydrophobic and the hydrophilic. Then manufacturers decide to simplify the system and to change the 2 bottles into 1 bottle, and they mix the hydrophobic and the hydrophilic part, and they put a simplified system. Then some markets decided that they don't want to etch, and they make an auto-etching systems in 2 steps at the beginning, and now they have materials that give you everything in 1 bottle. That means the auto-etching systems. What problems do we have with normal clinical steps that we do every day? So if we etch the enamel and then we etch the dentin, the problem is that we activate what we call some enzymes that we have in the dentin, and the problem is that the MMP are then degrade the collagen fibers. Then what is the clinical relevance of this? That in 5 years or 4 years, the problem is that we have some spaces between our restoration and the teeth, because there are some spaces, and the hybrid layer is not the same as at the beginning. This is a study of Armstrong that demonstrates that with electronic microscope. Other problems are about the application of the material and the solvent, the elimination of the solvent. So let's see the literature to know what we need to do about this. This is an in vitro study that demonstrates that the best thing is to apply 4 or more coats of the simplified systems. That means the etching and then the primer and the bonding in the same bottle. So what means to apply 4 coats? Means you apply 1 you wait, you blow the air to eliminate the solvent, apply another one, blow, apply another one, blow, and then you make the polymerization only one time. We don't want thick enamel adhesive layer, sorry. What we want is to complete the spaces that we are eliminating with the air, with the syringe of the air. And there are other articles that say, okay, we apply several coats, but how we do it? And this is a very good article that says that they make a clinical trial and they compare different restorations made with a slide mode, vigorous mode, and no rubbing action. And at the end of the study, 24 months later, they realized that the restoration that works better are the ones that were applying with the vigorous mode. About the solvent evaporation, we know that incomplete solvent evaporation leads you to permeability and decreases the bone strength. That means you need to eliminate the solvent. But the other thing is that complete evaporation of the solvent is impossible. So you don't need to follow exact rules of the manufacturer. You need to eliminate more prolonged time the solvent that the manufacturer says. That means eliminate more time, and then you are not only eliminating the solvent, you are eliminating the solvent and part of the adhesive. That's why you apply different coats of the adhesive, and you will have better results. Another thing about the auto etching systems, the all-in-one, is that they don't have enough strength, bond strength in enamel, for example, and they are like permeable to fluid movements only because of the polymerization lamp and the polymerization light. So sometimes we need to make something more to improve the addition of this type of adhesives. What can we do clinically as clinicians to improve our addition? So the first thing, not etch the dentin always. If you don't etch the dentin, you will not have the problem of the MMPs. So then you will have more success if you use an auto etching system. You always etch the enamel until now, but don't always etch the dentin. Always eliminate completely the orthophosphoric acid. It's very important because there are some orthophosphoric acids in the market that stays there in our restoration, in the teeth, so it's very important to eliminate it. So use chlorhexidine, 2% chlorhexidine during 1 minute after the etching phase to inhibit the activity of that MMPs. Apply several coats of adhesive and in a vigorous mode. Eliminate the solvent as much as possible. Remember, you eliminate the solvent, you apply another one. You eliminate the solvent, apply another one. Then, if you use a simplified system, use an additional layer of hydrophobic resin to improve your addition. And use anesthesia always you can. That means that if you use anesthesia, you reduce the content of water in the dentinal tubules in 70%. So less water, more easy to the adhesive to penetrate in the tubules, and better iris layer. That is what you need. And the typical question that makes the patient immediately when we finish our restoration, hey, this is going to last forever. So let's say, how can we guarantee an adhesive restoration? There are ones that goes very well, and this is something I made in 2005, a very easy restoration, it's nothing special. And you see it 9 years later, this is 2014, because we have a very good protocol, easy restoration, no problem. But what we can answer our patients, we say, okay, we know that in the literature says that after 5 years we can have some degradation of our interface between the material that we're using and your teeth. And what we're doing now is to put all we know or our knowledge to make this to improve, and we are using the last techniques to make this long, for example, more than 5 or 7 years in your mouth. And now what we realize is that if we use the adhesive in a proper way, we have very good success. The problem is normally dentists don't use the products in the proper way. And which one should we buy or should we use? It's always about the money everywhere. And if we follow literature, we need to say that we need to recommend to use etch and rise adhesives in 3 steps and self-etch adhesives in 2 steps. But the reality is that normally people don't buy this type of adhesives. Even the key opinion leaders recommend it. But the fact is that if you use any adhesive of the market, use it in a proper way. For example, if you use an auto-etching system in posterior that is very good for the dentin, use the auto-etching, etch prior the enamel, and you will have very good results. Apply different coats, eliminate the solvents so well, and you will have very good success. Another controversial point about composite resins is the liners. We use it or we don't use it. When we talk about liners, we only talk about 2. That is flowable composite and glass ionomer restorative material. Now the glass ionomer are increasing the use because now we're doing more prevention than we're more destructive. We're being eliminating so much teeth in the past, and now we know that if we don't eliminate, we will have better results. And about the flowable composite resin, what we need is something that is a good material to put in place and don't have so much bubbles and to have a good result. We put only a very small layer of flowable composite resin, and if we follow literature, people from classic articles, they say that recommends the use of flowable composites and ionomers as cavity liners. The article I mentioned before, that recommends the use of glass ionomer barrier to cover the access to the canals in endodontically treated teeth. Japanese, they say that the use of an ultra-thin layer of flowable composite to reduce the interface micro leakage and the incidence of voids in the restorative interface. And some actual books from like Ronaldo Hirata in tips, they say that use flowable composite resin in posterior to increase the marginal adaptation of our restorations. About anterior composite, that is where we're going to talk now. The most important thing is that we want a material that disappears in our mouth. We don't want everybody to say, hey, you have a restoration there and it's this brand. No, we need something that is more disappear in the mouth of our patients. This is how it was prior. What we do always is a protocol that we're gonna mention during the webinar. We put the dentin, some effects, the enamel, translucent. It's very important to follow the rules, to apply the acid etch, the adhesive, know what material you're using, apply, control the thickness. Very, very important to control the thickness. Now we have tools that allow us to control the thickness easier. And of course to reproduce the dental anatomy after the finishing and polishing, and try to imitate as much as possible a restoration that integrates in the mouth. But the most important thing is not to see the patient at this moment. You need to see it during the years, and this is the same restoration 5 years later. And when we see it in close-up, we realize that we have some problems here. It was an hybrid restoration. So the best thing is that it's composite resin, and we know now that we have better materials, so we eliminate the last layer, we change it, and we control the thickness of enamel, and we can have a very easy result in few minutes. We use composite resins in different situations, but always with the same protocol. It's knowing the material, have a step-by-step that is easy, is repeatable for everybody, not only for some people. When we have more aggressive breaks, we restore with different techniques, but always enamel, denting, easy, no problem. The most important thing is the anatomy. And what want the patients now? The patients want, please don't touch my enamel. So this is a case that we solved with a G-ænial anterior. And in this case, what we do is not to touch the enamel of the patient. And we solve it with G-ænial anterior. We only add the composite resin, obtaining the same opalescence, same effect that integrates in the mouth of the patient. Then we check the color with the polarized filter that give us the real color of the restoration and of the teeth, and we have very natural results without touching the enamel. The patient stays exactly the same that he was first, and then she's very happy. Very small tips in aesthetic dentistry, that very easy cases, that we need to know the material we're using, because if we try to eliminate this without that the restoration is seen, is viewed by the patient, is so important. More difficult cases, because this is 14-year-old girl, and we need to make something only with composite resin. This is how we finish. Always different views, and then always the review. This is 4 years later. It is integrated in the mouth. It's not the same as it was at the prior, but the most important thing is that now she's 18 years old and stays with the vital teeth, and she don't have any problems. So we need to know exactly the materials, and we need to control every part of the treatment. That means from the beginning, the preparation, from the addition, the certification process, and the finishing and polishing procedures. It's very important to have everything under control, to have a protocol to get to the goal that is the predictability, and to reproduce this every day. So let's talk about anteriors. And now we have the material. We need some tools that allow us to make good restorations. This is LM Arte from the Style Italiano group. We need to add two more things to the properties that we ask for the composite resins. We're talking about anterior. This in posterior is not so important. That is the fluorescence. And this is a photography of my friend Fernando Rey. This is a non-fluorescent composite here. And this is what happens when we go into the dark night. And here is a fluorescent composite, and if we have a patient that, for example, go to the disco or in some ambience, in some places that they have this type of lights, it's very important to give them a restoration that don't goes saying, hey, you have a restoration or a dark restoration or an excessive fluorescent restoration. And this is very well explained in this article by my friend Fernando Rey and Joana Souza, that they explain and how to evaluate the fluorescence of different materials. And the other thing that we need to add to the properties that we were talking, that were the handling, the polishing, the different shades, and the fluorescence is the other one, that is the opalescence. We need to imitate this effect of a natural tooth because we have now materials that allow us to obtain this type of effects. And the patient has these effects in their teeth, so we need to do it. And for the step-by-step, for the protocol, what we do every day is to make static custom photography. We make the color, we have some tools to make the color easier, diagrams to reduce the clinical time that we're using with the patient, the preparation, addition, stratification, finishing and polishing, and as I told you before, the reviews. If you review the case, you're training your eyes and you are revealing the whole. That is the sentence that I say in the first slides. When we do our cast, it's very important to have a good cast, stone cast models, and when you can reproduce, you can study the case and you can reduce the time you are with the patient. Clinical photography now becomes something so easy because we have tools that are digital cameras that allows you to make very easy photography in few seconds, and you can see the result totally immediately. So it's very easy. And normally I put photograph of small children. So if I can make a photograph of a kid, that means that it's so easy to make the photograph. I'm not a photographer, I'm only a person that can document the cases. So to obtain this type of photography is very easy. I normally use this type of flash for the anterior photography and the rim flash for the posterior one. What we need to see with the photography, with our eyes, etc. Well, we need to see the different colors that we have in the teeth and different parts. We need to reproduce this semi-opaque enamel that allows you to see the dentin, but not so translucent like here in this part, in the scissor part. The mamelons, the translucent part, the opalescent halo, we need to know that prior to try to imitate it in the nature. And the most important thing is to work in a working team, because if you work alone and you try to do everything alone, you're not seeing everything. You need to need the help of an assistant, other doctors, that allows you to see the color better than you see it. Some tools that we have now devices for the cameras that allows you to make polarized photographs very easier, that eliminates some information of the enamel and only can make you to see the exact dentin anatomy, makes you easier to reproduce it after. And this device is developed by Dr. Bathos. This is called Polarize, and you can obtain a static image. And now we can make the same thing with a device that is called Smilelight by Smileline of the Gruppo Style Italiano. And even we can combine new technologies like smartphones or whatever. This is software that is going to be improved in the future, and we're going to have better results there. And I'm going to show you example. This is a photograph made with a Canon 30D and with a twin flags, and this is the same case made with the Smilelight and with the iPhone 5. Sometimes this is a very good photography to communicate with normal. It's not only for documentation in a congress or for a course. This is the final result where we add the composite only to colors with the philosophy of Stile Italiano, denting and control of the thickness of enamel. This is G-ænial anterior. And then if we want to record the video to check the color and to test the final result, is very easy. This is something you can send by SMS or WhatsApp or email to your company, to your friends, to your technician, very easy. Other thing we like to use in our protocol is to make a diagram of the colors we're going to use prior to use it in the mouth. So here we don't like to think if we are going to use junior enamel in the palatal. Okay, let's put more here in this mammal. No, we write it first and then we do it in the mouth. And other thing, if you are treating a small kid, you don't need a lot of time. You don't have a lot of time to reproduce the dental anatomy. So what you need to do is to write it in a paper, make a draw, and then you can reproduce it very fast. So if you want to make these 3 lines or this type of developmental groups, important, draw it prior, and then it will be easier. Then we make the wax up. The wax up allows you to try the product in the patient prior to do it and to control exact quantity of material that you need to add to different teeth. In this case, we don't want to make any preparation, and what we do is to add this exact quantity to the canine, this to the lateral, and the same in the other side, but in the lateral we don't need, only a few material here in the distal part, but we control it with the silicone matrix. Kids, always the same. We need to control exact material quantity, then we make the wax up. It's very important to know how to make this type of wax up, because if we do it every day, it's a very good training to make it after with a composite resin. These are different views. And then to make the silicone matrix, I always say it's very important to have a proper manicure, because if the photograph is going to be done, we don't want, we want everything to be under control. We cut it with a scalpel and check it in the model, and always taking care, following Newton-Fall rules about the buccal incision line angle to have very good results and predictable results in an easy way and very fast. About the preparation. What type of preparation do you want for your mouth? Do you want if you have an accident and you have a problem in your teeth? So I like to mention Professor Baratieri, that he says in his book that ideally the need for any kind of preparation should be completely eliminated, especially with children and adolescents. It's very important to try to not to make a big bevel or a big chamfer to reconstruct a teeth and to make a restoration. Sometimes we have some problems because it's very difficult if we have not enough space to disguise the fracture line. Sometimes we can have some visual problems, but if we try to see the whole teeth, we realize that this is not a big problem, and the best thing is that the patient gains a lot because we don't eliminate his enamel. About addition, nothing more to say that we said before, but normally in anterior what we do is the total etch technique, and with etch and rise adhesive, and if we use 2 steps or 3 steps, normally literature says that it's more important to use 3 steps, but I always say if you use 2 steps, do it in a proper way and you will have very good results. And normally market and people, consumers are buying the two steps. So the most important thing is know how to use your material. So use it, do it in a good way, and you will not have problems. This happens to everybody that works. That you are working, you don't put the rubber dam there, and you are working near the gum, and this start bleeding. No problem. So some tricks that you can put a core. The most important thing is after you need to etch the preparation, just to clean it, the surface, and use some resin that allows you to complete your restoration without any problem, to finish the restoration that have a proper result during the long time. About the finishing and polishing procedures, following Newton fold technique, we divide the teeth in three parts. The first one is the primary anatomy, that is the basic form of the teeth. We do it with aluminum oxide disc. The second one is the secondary anatomy, that we do it, these developmental grooves, we do it with 5 hand piece, and with diamond bars, and with tungsten carbide bars. And then this, that is the tertiary anatomy, that exactly that the same that we have in the money. The most important thing is to know how to reproduce this with a 1/5 piece and a very slow speed. Now let's summarize this, everything that we saw in clinical cases. These are made with G-ænial anterior. They are going to show you two cases due to the time that we have. First case is orthodontic treatment case that we received this way, and we made two provisional restorations. Then when the brackets are retired, what we do is we propose the patient to make a whitening to improve the color of the teeth, but after 3 weeks, the problem that we have is that we obtain a very white teeth. And then in this case, we decided to choose a material like G-ænial anterior, because some colors that they have imitates very well the whitening teeth. And here what we do is the protocol, models, wax up, silicone key. Then we do our diagram. We are going to use these colors that are the enamel, junior enamel, incisal enamel, translucent for the effects, and the bleaching white like the dentin. We make the etching. We go teeth, one teeth individually. We apply the adhesive layer, then the palatal, following what we draw in the picture and what we see during the diagnostic phase. Apply the different stratification masses of the material. Then we cover the restoration with oxalate gel to improve the polymerization. In this case, we modify the emergence profile with metal matrix. Then we use this type of strips to polish the interproximal part. These are the Epitaxy one. That the advantages that it has is that they don't eliminate too much the anatomy of the teeth, that we make it with very slow to have a very good shape. Different grades. This is the immediate result. And the most important thing is to check the material, check the cases after. This is prior to do the whitening in the lower incisors, and this is their view when we do the whitening there, and we have a very natural restoration that integrates in the mouth. And the other case is a very small kid but with a big fracture. There is no other material that the composite resin to solve this type of cases. We make the diagnostic phase, as I told you, photographs, models, photographs with the polarized system, and we make a diagram, the palatal cell. We're gonna use, in this case, the inside colors to disguise the fracture line. We're gonna use the junior enamel for the palatal, and this the A02 color for disguise the fracture line. Then the mamelons that we're gonna use a standard color, A2. The translucent, that we're gonna use a translucent enamel color. And finally, we're gonna finish the restoration with a junior enamel. After making the isolation with the rubber dam, what we do is to check our silicone matrix and go through the addition process with the etching. Prior, what we do is to seal the entrance of the endodontic access with a glass ionomer. Then we apply the junior enamel. Then the A02, you see that we have the opacity that allows you to disguise the fracture line. Then the dentin to reproduce the natural dentin that we saw in the diagram prior. Then the translucent enamel here. And finally, the junior enamel to reproduce the enamel, controlling the thickness with spatulas like the Misura instrument or different spatulas that we have here. And make the finishing and polishing procedure to have a proper anatomy. In this case, we add some white tints to try to imitate the effects that we have here in the adjacent teeth. This is what we have. This is the final X-ray. This case was made in collaboration with Dr. Eugenio Carlos Grano de Oro Cordero. This is one of the best endodontics in Madrid, in Spain. And then what we do is to check our restoration with the polarized system, static photograph and dynamic polarized system with the smile light, and this is with the polarized. And always review the case just to, what I say at the beginning, check what you're doing and reveal the whole. And I always like to thank everybody that is watching me. I hope you're watching me. I know you're there. And I always like to finish with this sentence that is from Charles Chaplin that says, "The smile, though your heart is aching." And now let's go to the questions. I'll try to answer everything that you ask me. Okay? Thank you so much.
Answering Maria Madonna, a question about if I recommend the use of biodentin as a liner. I have to say that I am not a user of biodentin. Still, I don't use it, but I'm reading literature that I think it's one of the future in restorative dentistry. And but still, I'm not a user of biodentin. And the second question that you make it if I etch after place the liner. If I place flowable composite, I don't etch after that. What I do is to etch prior. But if I do it with a glass ionomer, yes, I etch after, but I don't etch the surface of the glass ionomer. More questions? Is it okay with the sound? About Omar, he asked me what do I think about the color composite from GC. It's a great material. I only use for posterior, and still I prefer to use regular composite like a G.ænial or other brands to make the restoration. Color is okay, but I prefer the management of other type of composites. I prefer G.ænial management instead of Calore. Alan Brown asked me what kind of bonding system I prefer to use. I have to say, in posterior, I normally use auto etching systems, but always etch the enamel first because they still don't have enough bond strength in the enamel, but that's very good to avoid to etch the dentin with normal etching systems. In interior, I prefer to use two-step systems. I mean three-step systems is etching and then the primer and the bonding separate. But as I tell during the lecture, the most important thing for me is to know the material I'm using and try to use it in the best way. So I don't care if I use a two-step system or three-step system, or I try to follow the steps to obtain the best from the adhesive system that I use. But if I have to make a resume, I say I would always use like a universal system, auto etching system in the posteriors, and in interiors I will use some etching and primer and bonding in separate way. Well, they tell me that when I see micro leakage of and discoloration of the restoration, what is usually the cause? I think in my practice, normally if I see a micro leakage, it can be I don't etch in a proper way the enamel, or maybe some occlusal problems. But I will go more to the etching and adhesive stage. Prior, I don't invert so many time in my adhesive system and in my adhesive phase. But now what I do is I spend enough time to make my adhesive phase the most in the best way, so I can obtain very good results and don't see that micro leakage. And about discoloration, it can be the habits of the patient, and of course, if we use some hybrid resins, the problem is that maybe they are not polished enough and they are not in a good way. So I think it's both things. It's first question is I think it's a problem of the conditioning, the addition, I think, etching and addition phase, and the other thing is the polishing of the material. Omar, for posterior teeth, I use sectional matrix. I normally use Garrison system. I use the system from Paladin Plus from the supply, but in most cases I use a Garrison system. The most important is to use a sectional matrix and silicone wedges. And the ring, it's very important, the ring too. To use a proper ring to obtain a very good contact area, contact point. Okay, Christian Kalinov asked me how often I examine and repolish the restorations. Normally, I make the recall of my restorations every 6 months. But if it's a patient that has a high risk of caries following the CAMPA protocol, or if they have not good enough hygiene or whatever, I try to see it every 3 months. But normally, I repolish them every year if they need it. If it's with restoration, believe me, I don't touch it. But normally, it's every 6 months I review my patient. Every year I repolish. But if it's an hybrid composite that I use more in the past, it's more often. It's every 6 months I make the repolish of the material. That means how to save the tooth aesthetic. Well, I don't understand very well the question about how to obtain a good aesthetic shape. I can tell you it's only a way to practice anatomy and study anatomy of the teeth. Watching natural teeth, I always try to imitate it, using correct tools like spatulas, brushes, but the most important thing is to know the anatomy, study the anatomy of the natural teeth, and then you can obtain very good results. Okay, Maria Madonna asked me if I use chlorhexidine in all restorations, all in the posterior ones. Well, normally I use it in the posterior ones, but if I have an anterior restoration that has more dentin than enamel, for example, in patients with erosions, in patients with that they have some problem of acidic problems with, they eliminate the enamel itself. In that cases, I use the chlorhexidine after the etching phase. Nagrendan asked me, show some cases of G.ænial in class 4. I saw you during the presentations 2 class 4 cases. I think we don't have more time, but I will be very happy to show you more cases. But during the presentation, the last 2 cases are in G.ænial. There are class 4 restorations, and in the clinical part, I mentioned what are G.ænial cases. Well, Marie asked me what do I use for polishing, diamonds or flatted bars. Well, for anterior, normally I use disc, aluminum oxide disc, and then I use some rubber points and diamonds and flatted bars. Always I start with the diamonds and then I finish with the flatted bars. And after that I finish and make the shine of the restoration with a disc and with some aluminum oxide paste. Omar asked me, do you have any adhesion system for broken porcelain with composite? Well, it's the problem every time that we have broken porcelain is that we need to repair it, and the adhesion is not so much predictable. Sometimes we go to some courses and congress and we see the photograph, but then when we go to the real clinic, we realize that it doesn't work so well. The thing that best works in our hands is to make the fluorhydric acid phase and etch the porcelain, put the silane, and then put some heat. And then what I do is try to put a 3 steps system analysis, that is etching the again the porcelain, but only to clean it with orthophosphoric acid, and then to apply several coats of the primer and then the bonding and then the material. But always when I make, when there is a broken porcelain, I try to replace it, because if not, there is always that little piece that is always broken. Dan asked me, the color of resin we choose the same like patients do, it's so difficult. So do you have any tips about this? Okay, now as I show you in the presentation, I use the lamp of style Italiano that it's called Smile Light. Then it's a polarized light that allows me to eliminate some part of the reflection of enamel, and then allows me to get a better real color. Then with the recipes that we have for the composite resins, what we do is, if for example we have an A2 color, a Vita guide, we put the dentin and the exact thickness of enamel. We put a 0.5 thickness, and then we can obtain more predictable results. So now with the photographs and with the coloring devices like the lamps, we can obtain very good results. I need to recommend you that if you want to make a good safe color match, you do it immediately when the patient goes to your office, and we do it with the lamp, and to make 2 or 3 registrations, one by yourself and other with your assistants and people that work with you. Omar, sorry, I don't understand your question. You put me, are you with teeth within or against? If you can write again the question, that means if I am a person that I like to maintain the teeth, I have to say yes, of course, and I try to eliminate as less enamel as possible. But if not, please can you write again the question? Mm-hmm. Marisol King. I believe he means, how do you best shade match your resin composite to your patient teeth? How you choose the best shade of composite to use? Okay. How I match? What I do is I have individual shades made with my shade guide tool of the material I'm gonna use. For example, if I'm gonna use G.ænial, what I do is I have my own individual shades of G.ænial, and then with the lamp I make the color match, and then I select the color. That means if I'm gonna make a combination of A2 standard and a junior enamel, I have my shade type with the combination of A2 standard and junior enamel, and then I use my shade guide, and then I make that color selection. You say Omar, you asked me if I make the whitening of the teeth. Yes, of course. I make a lot of whitening in the teeth, and I think we don't hurt the tooth, but we need to do it in a proper way, of course. I normally use home bleaching, and I have very good results, and I have great results. Believe me, every patient is very happy with the white teeth. Now I understand your question. Oscar Adriano, what's your preference for polish and restoration? Well, I tell it before. I use a Softlex system for anterior. Then I use diamond bars from Comet and flatted bars or tungsten carbide bars. I do it with 1/5 hand piece, and then I use some FlexiBath or some disc that allows me to make the shine with a special paste of aluminum oxide paste. It's not a problem. But the most important thing is go step by step. Know exactly your material. If you use a microfiller, it's going to be less steps. If you use a hybrid resin, you're going to have more steps. Know your material, and it's better to do it. Galina, Dr. Villares, your smile is contagious. You should smile more often. Thank you for your wonderful presentation. Thank you, thank you, Galina. Nevena, do you have any cases with sensitivity of the teeth after restoration? How can we okay. Nevena asked me if I have sensitivity in my teeth after restoration. The question is not. That's how can I obtain that? Always making the adhesive steps very carefully and not to be in a hurry. If you etch the enamel, don't etch the dentin or in posterior, and then apply several coats of the primer or the universal system if you're using an auto etching system or whatever. And that will be the way to avoid the problems in posterior. In anteriors, normally I don't have it. Maybe in class 5, but in the past when I etch all the dentin and enamel. But now actually I don't etch the dentin, even in class 5. I only etch the part of enamel, and then I apply several coats, and I do it in a proper way, and I don't have problems. Alan, you asked me how did you make the matrix for the composite to repair incisional edge of the anterior teeth? Well, the matrix, I normally, if it's only a small incisional edge, I will not use matrix. I will do it by hand. But normally what I do is to make a wax up. Then I obtain a silicone matrix for that wax up. And then it's the way to obtain a predictable result. What I do is to put the matrix in the palatal and then apply the first coat, the first layer of the enamel, and then I put my composite resin. It's very easy, but I will do it if it's very small. You can't put your silicone matrix, and sometimes we do it by hand. Marisol, then you have a very deep proximal lesion, class 2. Okay, Marisol, you asked me how I make the management of subgingival restorations. Well, normally, if it's very subgingival, I try to do it in 2 steps. That means what I do first is to make the deep margin elevation. That is the technique described by Pascal Magna and Roberto Spreafico in the article I mentioned during the lecture. And then what I do is an in-depth restoration. Because sometimes the problem is that if we try to manage the restoration subgingivally. It's very difficult to have a very good contact area, contact point that allow us to make a good function. So if you don't want to make an indirect restoration, what we do in that situation is make it in 2 steps. First step, what we do is to make the margin elevation, and then we change everything and put a sectional matrix system to make the contact area. But I will do always in 2 steps. The best way is to make the second step in an indirect way with an onlay or an inlay. Canute. How come mechanical bleeding happens after flossing to remove during cementation of veneers? Okay, if you don't want to have problems during cementation of veneers, please use the rubber dam and floss it and put it with a knot. And another good trick is to give the patient chlorhexidine during 1 week during the provisional phase. Then you will have less problems during the cementation. But what I try to do is to be the first. That means be faster than the blood. The blood is always there, and we need to avoid it. My patients are exactly the same as all of you, and they have problems with bleedings, and they have gingivitis, and we try to do our best in our practice, but sometimes we have that problem. So what we do with that is try to treat every patient if we're gonna have problems with bleeding. Then use rubber dam, thick rubber dam, and then you will have no problem. And if not, you can have retraction cords with some retraction paste, and you will have very good success. Oh, thank you, Marisol. Thank you. I hope all of you like it. So it's my proposal.
Thank you very much, Dr. Fernandez-Villares, for sharing your lecture and your insightful information with us. We'd also like to thank DT Study Club for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Fernandez-Villares may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Fernandez-Villares will be sure to get back to you as soon as possible. Please be sure to visit the DT Study Club educational platform, www.dtstudyclub.com, and keep an eye out for our growing schedule of online courses. Thank you again to all, take care, and goodbye.